Hello, I'm Daniel Browning. Welcome to this program, Sharing Solutions, Indigenous Communities Tackling Chronic Disease. On behalf of everyone, I'd like to acknowledge that we are meeting on the land of the Wongal people. The Wongal people are the traditional owners of this land and form part of the wider Aboriginal nation, known commonly as Eora. We also acknowledge the elders and the descendants of the Wongal people. The gap in life expectancy between Indigenous and non-Indigenous Australians is about 10 to 12 years. Most of this gap is due to preventable chronic diseases, such as diabetes, lung, heart and kidney disease. In this program, we'll emphasise the need for a new approach to their prevention, treatment and management. We'll examine risk factors and look at some of the ways that Indigenous communities are tackling the problem. In other words, we'll be sharing some of their solutions. There are also a number of useful resources available on the Rural Health Education Foundation's website, www.rhef.com.au. Now, let's meet our panel. Dr. Alex Brown is currently the head of the Centre for Indigenous Vascular and Diabetes Research for the Baker IDI Heart and Diabetes Institute based in Alice Springs. Dr. Sally Gould is a Wiradjuri woman and currently the chairperson and executive director of the Congress of Aboriginal and Torres Strait Islander Nurses. Dr. Mark Wenatong is from the Gubbi Gubbi Tribal Group of South Queensland and he's the Senior Medical Officer at Opunapima Cape York Health Council in Cairns. Deanne Minnicon is an Aboriginal and Torres Strait Islander woman from Queensland. She's a Senior Health Promotion Officer with Queensland Health. And currently she chairs the steering group of the National Aboriginal and Torres Strait Islander Nutrition Strategy and Action Plan. That's a mouthful. Welcome to all of you.
Thank you.
Okay, just to get started, we're going to talk about this whole notion of, I guess, a singular idea or a singular conception of Indigenous health. Mark Wenatong, could I direct my question to you? Is there one perspective on Indigenous health?
Look, I think the issue is that the Indigenous people occupy a whole lot of spaces across the kind of intercultural space. So, and there's different perspectives on that all the way through. So we're talking about, you know, some traditional people, right through to urban, Aboriginal, well-educated people. But having said that, somebody who's urban and educated, it doesn't mean to say they don't have traditional views on lots of things, and vice versa. So there's a whole lot of spaces along there, and for clinicians that work with Aboriginal and Torres Strait Islander people, it's really important to try and contextualise it with the people that they're working with, to get a bit of an idea of where they're coming from and what their health beliefs and their belief systems are, because it's got, you know, huge implications for the way that you practice and for the way that patients pick up your management regimes and stuff like that, and that whole issue of compliance, which, you know, is a bit of a loaded kind of a question, but how that works in practice is based a lot on the Indigenous person's perspective of what they think health is and what causation is, and it's also based on what the you know, health professional, the stuff that they bring to the interface as well. So,
Alex, you may have a different perspective. Is there one holistic notion of Indigenous health, or are we just, is that a myth?
I think Mark's point's really important here. There is a lot of heterogeneity in terms of the way in which people understand health and what might be contributing to illness. From our experience, there are a couple of really fundamental things which are held true across all of the Aboriginal communities we've certainly dealt with. And these are things like the importance of connectedness, of the importance of family, of maintaining harmony in relations between individuals, within communities and with communities and broader social structures. So, and the importance of land and place, and that connection to it is really important too. So, while there are differences, there are also some unifying things that are important for practitioners to really know. And the only way to know is, as Mark suggests, to get in conversations with patients and families within that local context and try to understand where people are coming from.
Sally, you'd also have a different perspective on this question. What do you feel?
Well, I believe as there is diversity in mainstream, so too is there diversity amongst Aboriginal and Torres Strait Islander people. And I, pardon me, believe that one size doesn't fit all.
I guess one of the dimensions we have to consider when we talk about this notion of Indigenous health is the well-being of the community. We often talk about how you can't have healthy individuals in a community if the community itself is not healthy. Deanne, what's been your experience of this whole idea of well-being in the community translating to the well-being and the health of an individual?
Well, I guess an individual, and not for all Aboriginal Islander people, but for some Aboriginal Islander people, an individual health will impact, will be determined by the family, by community as well. And so if the community is well, in some cases it may be that individual will not be well because the community is not well.
And I guess, Mark, you touched on this, the difference between the urban, regional and remote settings. What are the major differences, as far as you can tell, between our communities and spread and as diverse and as spread as they are?
Well, I think it's probably much more about the common things that Alex talked about rather than the differences. The differences, I've made mistakes before in clinical practice about assuming things about Indigenous patients. Young, urban, sort of educated people who will have a very different idea about illness causation than what I think they understand. And when I think they understand Western concepts of disease pretty well, and they actually think quite differently. It's really interesting to go into different communities and work, lots of people work across Australia in different communities everywhere from the Torres right through. And the diversity is pretty amazing. But as Alex says, there's a lot of common themes as well. And I think for clinicians approaching Indigenous communities and working in Indigenous communities, it's really important to understand at least the common themes so that you've got some basis to build on. Can be very different, approaches to everything for, like the Torres Straits traditional adoption and a whole lot of other things that they do there, as compared to Central Desert Aboriginal communities where other things are, very important around men's business and women's business and things like that.
So our Indigenous conception of health is not just our physical well-being of our bodies. It runs much deeper, doesn't it, Sally?
It does. Community health and well-being, and I think that a lot of Aboriginal people consider if that there is harmony in the community and community well-being, that all is overall well, that though they may be ill, they don't consider themselves ill if there's a feeling of well-being within the community.
And if there is this Indigenous perspective on health, has it evolved over time? I mean, we can talk about the great advances, I suppose, in management of chronic disease in Indigenous communities over the last 20 to 30 to 40 years. Are we developing a more integrated way of seeing Indigenous health?
I think there's a couple of ways to answer this. One is, are Indigenous people taking on Western medicine and understandings of health? Well, they certainly are. And culture, there are elements of culture which will never change, but there's also parts of it that do change because you can't survive if you stay still. And that's how Aboriginal people have survived through time. The other question is, does Western medical science accept the way in which Aboriginal people view the world, and has it integrated in some way, or has it developed a more nuanced or broader understanding of health? And I would suggest that it hasn't yet, and if only it would, then it might be better for everyone.
That's the area where I think we really need to do a lot of work. I think we've done a lot around evidence bases and clinical medicine. And we've got pretty good evidence around how to approach health and chronic disease and best practice. But the interface between us as health professionals and Aboriginal people as individuals and as communities, I think we've got a really long way to go there. And it is, you can see it when you work with traditional healers and you see that they get almost 100% compliance, probably because people are scared to death of them. But, having said that, they do get that. They understand the way people think, and they manage that in their treatment regimes, and people do what they tell them to do. And for us, we come in and we don't get, obviously, we wouldn't have a problem if we got 100% compliance with, so we don't even get 100% compliance in, mainstream GP practice in Australia, so it's really difficult stuff. But we really need to think a lot more about that interface, and it's just not the medical part of it, it's how we relate and how we interact that can really make a big difference, and that's something we haven't really done much work on at all, I don't think.
Could I make a comment, please?
Absolutely, Sally.
Mark, I have to take you to task about the word compliance. It's a word I don't like because it to me denotes a power relationship. And I think to care for people, you need it in partnership, not as a power relationship. I'm sorry, Mark.
That's okay, as my elder. I'm scared of you, so you can say whatever you want.
Now let's take a look at our first case study, the Yarrabah Family Wellbeing Program, where the goals are to build and strengthen the social and emotional wellbeing of individuals, their families and their communities.
We want a crisis, crisis with a family, crisis at a workplace, crisis in a community. You have a family crisis?
Oh yeah, I just stopped drinking and that and just walked away, yeah. Come near the men's group, you know, really helped me in it, for support and that.
The men's group started just after we had a string of suicides here in Yarrabah. We had one of the highest suicide rates in the world. I think we were second in the world. It was pretty devastating back in the early 90s. And some of the men at that time were feeling confused, bitter. So a group of men got together and formed this men's group.
It was good for our community to offload how they were feeling, but also get their ideas on solutions, how we can fix this. We started getting people in from the University of Queensland that was training us up in Family Wellbeing Program, which is our core program.
The Family Wellbeing Program, it's an accredited counselling course. It was developed by Aboriginal people, for Aboriginal people. And that was in 1993 in Adelaide. And the people that developed were people who were part of the stolen generation. It's 5 stages. It looks at understanding relationships, listening, having compassion, looking at your life journey. It's about understanding yourself. It's about balancing the body, mind and emotions.
Just be a man of what you do and how you go about it, you know. Just be a man, just stand up and don't be afraid to show your emotion. And
we all had this perception of men had to be this particular type of person, you know, very strong, very closed about our feelings and emotions, you know, and we knew that wasn't right, you know. We knew that we're human beings and men needed to express themselves. So we felt by involving men in a group and having a program such as the Family Wellbeing, it would allow men then to offload some of the pressures that they were experiencing at that time.
me and my woman, we're back together and like we're going all right now. We're no fighting, we're not arguing. We're just going on smoothly, you know.
I'll come and see anyone there from the men's group there.
Just hold up, I'll just get someone for you on the line.
If a male comes to our door,
Good morning, Dennis.
we usually get one of our male health workers to go and have a chat with him and find out what's the underlying issues.
Okay, yeah, we'll just step in this room here.
Young fellas out home there, breaking in there, broken home there. Just come back from holidays and that. I'm really angry and I don't want to go and get them boys, you know. And it's not going to solve no problem, mate.
If you'd like to come in and attend men's group and we can lay it on the table, you know, and see what other men think about, you know, possibly get us some more solutions to help you out, brother. Yeah, that's what men's group is all about, trying to sort this out as men, you know, how we used to do it before, our old people.
We would then sit down and have a case planning meeting where we would bring in the rest of our team, which is made up of the men's and women's health, and also our BTH counsellor for people who are suffering from generational trauma. So you said that he's frustrated? You feel like harming someone, did you say?
Yeah, he's harming these youths who broke in.
Is he only angry because of the break-in and enter, or he's been experienced that anger before that?
Just with the break-ins and the frustration with the police.
We might need to go door knocking and see if anyone would talk to us and see who the children are.
Well, I think we need to deal with this one quite rapidly. Over the last 10 years, I've seen huge changes. I think we're looking between 80 to about 98% reduction in suicide here in Yarrabah.
Well, I was gone with my ex-wife for 15 years. And when she told me she was seeing someone, and it really affected me, and I went on a drinking spree for about 3 or 4 days. And when I finished drinking, I saw my kids standing around me. It was pretty sad to see the sadness in their face.
Myself and my wife, we both been sexually abused when we were younger, and because I had a sort of hatred towards women and she had hatred towards man, and it was just a clash all the time.
I had hatred for her. Hatred was like a big ulcer in my guts, and it was really killing me.
And then when this family wellbeing came out, and we got the training and facilitators training, and we went through it, then I started to apply some of it to my family. I brought it into my home because I needed to reprogram my mind, you know, because just growing up with that mentality, how we should live, that's how we should treat people, and it was all wrong. But then I got these tools that reprogram my mind how to find solutions.
It brought a lot of healing in my spirit and my soul, and emotionally and mentally and physically, you know, strong and fit. You know, it helped me a lot. It's a guide for my life and prevent me from doing wrong things, but also to share with other men out there who experience the same thing what I experienced, or other things that, you know, they can get healed. Take some deep breath, have time to think, stay calm.
I think I learned to be humble, because one of us had to change, because my family was going downhill. So I rose up, you know, and that's part of men's group's vision, is to restore their rightful role in the family. I tell you, when you sit back and reflect on what we used to do, gee.
Your life, yeah.
Hey, I can't believe I did that.
Yeah, that's true, eh?
Someone who's got a crushed spirit or is full of anger or bitter feels emotion that really plays with their physical parts in their body. And we believe that through social and emotional health, we could address those issues that hopefully will address the chronic, you know, health diseases that we're currently facing in most Indigenous communities.
Mark, talk about the success of that program and why you think it's succeeding.
First of all, I think they're really brave, those men that come on, and we'll talk about some of their personal issues like that. I think that's fantastic. But I think one of the things that sticks out in that for me is that there's a theoretical or conceptual underpinning in the way they're approaching that program, and that's empowerment of people. So this is working with people to be able to take more control back over their lives in small incremental ways, and in a real framework. So it's not just touchy-feely, there's a framework involved in this, and those men are growing through that, and it will affect other aspects of their lives like the physical, etc. But I think it's really important that when we're looking at developing health programs in primary healthcare, that we look at all of the whole person. And when we're looking at those kind of things, you know, we're empowering people. And I mean, Alex can talk a lot more to the control, you know, control as a risk factor for cardiovascular disease and things like that. But there's actually, you know, scientific basis for this as well. But it's really important to be able to work with the whole person, I think, and I think those men demonstrate it really clearly, that there's lots of things that they can change in their life, but they have to be empowered to do that, and there has to be some framework or process. And I think when we do primary healthcare, we kind of just go on with the clinical stuff and forget about some of the other things.
Alex, how does Yarrabah compare to Central Australia?
Well, I mean, the issues that were presented by those gentlemen were the same stories that we hear in places around Central Australia. Even down to the commentary about explanations, you know, guys with crushed spirits, you know, are going to be physically unwell. I mean, that's very strongly the story we get. And I think, you know, it's a very important lesson for us. One, as Mark mentioned about, you know, communities can develop their own solution. They need the right frameworks and support around them. But secondarily, if we're going to make a difference in chronic disease, if we're not dealing with where people's hearts and spirits are, we can't actually make a difference in chronic disease. So it really is a very important eye-opener for us as a system. If we're not dealing with people's emotional well-being, we can't possibly hope to engage them around chronic disease.
Sally, can you speak to that? The disconnection between, you know, the physical body and the emotional self. I mean, are we taking care emotionally? Are we taking care of Aboriginal people?
No, I don't believe so. Because without knowledge of the history, it's very hard for people to understand the difficulties that many Aboriginal people have gone through. And I think that it's a great description, I guess, or explanation of how closely entwined our soul and emotional well-being are with our physical well-being. It's really interesting. A few years ago, Gifford stated that people who have been deprived develop soul sickness, and that I think is a really quite apt term for many of our people, that they are soul sick. And the gentleman on that video who said his soul was crushed. And why was this? One has to ask.
And also, one term I want to pick up on that the gentleman raised in that package, and that was this whole question of intergenerational trauma, which some people watching may not be too aware of. Just in layman's terms, can you tell us, Mark, how that translates, or maybe Alex, how that translates for us Aboriginal people, because we know it exists. It has real health effects.
I think Alex is actually going to talk a little bit to this later with some slides and things. But it's the way that trauma is born across generations, really, and the way that it can affect people both physically and spiritually and emotionally along the way. And I guess the bottom line for health professionals is, if you're trying to give somebody some pills for diabetes and they don't give a rat's, they just don't give a rat's, they're not going to take them. And that's what we're trying to get at here, I think, and I think that's what they're trying to say with that program, is that you've got to deal with those intergenerational issues and the way that, you know, people's, what we call their spirits are like in today's society, particularly in rural and remote, but in urban settings as well. And without dealing with that, it's really hard to say, well, of course they're going to do everything I tell them to do with my, you know, diabetic regime and things like that, and they're going to exercise, you know, an hour every day, 5 days a week, and blah blah blah. When they're in that kind of condition, they're not going to listen to you. So you do have to do that. I mean, don't get me wrong, we still have to do best clinical practice, and we have to do everything we do, and we can make some difference with that. But at the end of the day, to make real difference, which is what we haven't been doing so far, you have to engage with those issues.
At that point, Alex, I should ask you, can you give us an overview of chronic disease? I guess it's important to state what these chronic diseases are and how they affect our Indigenous communities.
Yeah, okay, look, I mean, chronic diseases, it's very hard for people to really, you know, understand what chronic diseases are from a community or lay perspective, because people know when they're sick and they seek help when they're sick. The problem with chronic disease is it's a long-standing, lifelong, non-curable illness. Now, when we talk about chronic disease in Aboriginal communities, we tend to focus on diabetes, heart disease and kidney disease, but there's also other chronic conditions which are probably important. Chronic lung disease from smoking-related injuries, and also depression. I think, you know, the case study from Yarra really talks to how important it is to include that, you know, emotional component as well. So they're probably the big players in the chronic disease space for Aboriginal communities at this stage. Cancer is important as well, but it tends to get less airplay in Aboriginal communities at this stage, but that won't last forever. Now, what we do know is that the impact of chronic disease across Aboriginal communities is enormous. You can see from some slides we're going to put up now. Really, this first slide gives us an idea of the sort of proportion of people who are dying at a given age. 0 on the bottom, right up to 80, up towards the top. And we're comparing here Indigenous Australians on the left-hand side and non-Indigenous Australians on the right-hand side.
I mean, it's visually amazing, isn't it? I mean, the discrepancy.
They're completely different population death profiles. You can see that Aboriginal people are far more likely to die in young age, and really the vast majority of that is in middle age. What we're finding is the primary contribution to this pattern of death is really from chronic disease, early and preventable. Now what we know is that the chronic disease is the #1 contributor to the life expectancy gap. We all talk about closing the gap. It's now become part of the vernacular. What we know is chronic diseases are the most important contributor. What this slide really shows is the top line on both sides is the life expectancy for a non-Indigenous Australian. The bottom line is the life expectancy for an Aboriginal Australian. You can see there's a massive gulf between the two. And the different colours are really trying to unpack what the causes are within that space. And you can see the big green bit on this slide is really how much chronic disease contributes to that life expectancy gap. So together, heart disease, kidney disease and diabetes contribute about 75% of the life expectancy gap. So of that 17 years, the vast majority of it is caused by chronic disease. So we have to be doing something about it.
I mean, we all know the history. We all know how bad health is in our communities. But seeing those slides, even if you can't decipher all of the content, you just see those disparities. There's such a gulf. It brings it into sharp focus. Mark Menatong.
The other issue there, I think, to be mindful of is the population growth projections. So for Indigenous people, especially across the top end where we've seen projections from CAPER, they're projecting 39 to 42% population growth by 2015, and by 2015, which isn't that far away, and compared to the rest of the mainstream Australian growth, which is relatively static. I mean, it's 2% or something like that, if you don't count refugees and everybody else that's coming into the country. It's the population explosion is going to be around the middle-aged group, and that's what they're projecting. So we can really expect more chronic disease and higher levels, and a bigger morbidity load in that age group. So it's something we've really got to do a lot with now, rather than waiting.
What then are the social determinants? I mean, we often hear that phrase, social determinants, but what are the social determinants of health that are of particular relevance in our Indigenous communities? I mean, things like unemployment.
I know Mark's got particular interest in this area, but I'll kick off. We know that across any population, poverty is really bad for your health. So if you don't have a good income, if you're not employed, if you don't have a good education, you live in bad housing, you don't have access to healthy infrastructure, we know that those things are important contributors to poor health in pretty much any population you'd care to meet. The difficulty in an Aboriginal setting in Australia is that those markers tend not to work the same way they work in non-Indigenous communities, because I get $1 in an Aboriginal community and that dollar's up for grabs for everyone. So you don't preserve the health protecting benefits of that income necessarily. And similarly, there's a whole bunch of other things impacting on health status. So those social markers are probably likely to play a bit differently. The work we've looked at is really, how important people's sense of control over their own life is, whether or not they feel that they've got a say in their future, whether or not they feel that they've been, done wrong or harmed by, the social institutions of their life, whether those things have impacted on them, and the impact of racism. And these are social determinants that are very important in an Aboriginal context as well.
Because, racism has health effects, doesn't it, Mark?
Yep, and they're measurable health effects, and there's some reasonable studies from the US with black Americans on the effects of racism on blood pressure and a whole lot of other things that are measurable. The other thing to think about, though, with social determinants is there's some positive social determinants as well, like social capital. So this is like the whole extended family taking care of each other thing. I mean, we often see the dysfunction, but we often don't see the added benefits of having lots of people taking care of you and sharing and a whole lot of other things that are quite nice. I mean, we learn a lot from some of this stuff, and you find that lots of clinicians and people that go to live in Aboriginal communities for various lengths of time come back with sometimes changed attitudes towards material things and things like that. So there's some positive aspects to some of the social determinant stuff, and I think one of the key ones is the social capital or the social networks and family supports and extended family supports. And I'm not sure if we utilise that enough when we're trying to promote good health programs and things.
Dan, what do you have to say about that? I mean, excuse me, excuse me. It's really important to remember there are very many positive things about being Aboriginal, and one of those is in our family relationships, and you know, when our families have broken down, we see the effects. But you know, the strength of our communities is also something really important to emphasise here. Yeah,
and I don't think it's valued enough by health practitioners, I suppose, when they're saying go home and do this sort of, you know, manage yourself this way in terms of your health. They forget that the family, the extended family, are the ones who are going to support you in doing all that sort of work in terms of improving your health outcomes. So you could be, this week I don't have any money to go out and buy the food that I need to buy to help manage this particular, you know, illness, but you've got family to call on all the time.
And how does the whole question, we often hear about being connected to land and connectedness, but how does this relate to urban Aboriginal people? Is there a marked difference?
Look, I think there would be, as we mentioned before, heterogeneity or difference is really the calling card of Aboriginal Australia, rather than necessarily, you know, the similarities across everything and one size fits all. But connection is important in any context, and it's not just important for Aboriginal people, it's important for all Australians. I mean, if only, as Mark was saying and Deanne was saying, people took stock of how important and how useful as a health promoting thing being connected is, then, you know, we'd all be better off, all of Australians. So connection is fundamentally important. It's what defines that connection and what connection to that really is valued by that individual that's important. And that can be land, and for many people it is, or that can be an identity, or that can be where your family's from, or that can be your family, or that can be a social network, your football club. I mean, these are all health affirming processes, so connection's very important.
It's interesting too, there's a few, you know, studies that have been done on this kind of stuff. One is coming out of Darwin, which was about rangers working back on land, and their control of blood pressure and sugar and how that affected them. And they got positive results from that, measurable positive results. And the other thing I think that's really interesting has been the work that Robin McDermott did earlier on with very remote. So we're talking about outstations, really people living on country, and with that, and Alex can, if I'm wrong, I think the data hasn't changed. There was they had a 10 years better life expectancy than people in just remote communities. So these were people who'd gone from the artificial communities where everyone's shoved together back to live on country. And at that stage, you know, it's an older study now, so I'm not sure if anything's changed. But certainly when we did the mapping for a geographic information system with NHMRC for the cardiac rehab manual, the statisticians looked at that and thought it was a mistake. So in very remote locations, the life expectancy improved, and that is likely to be related to something to do with identity and land and being in touch with country, but you know.
Well, what then are the main risk factors for chronic disease in Aboriginal communities? I think we know what they are, but...
Well, look, there's a whole raft of them. What we know across the world, in sort of any population you care to look at, the same risk factors are the primary cause of chronic disease. So whether you're from Pakistan, whether you're from Central Australia, whether you're from New York, if you've got high blood pressure, if you've got high blood cholesterol, if you smoke, if you're carrying too much weight, particularly around your stomach, if you're exposed to poverty and disadvantage, and whether or not you've got diabetes, those things are potent contributors to chronic disease. So that plays true across pretty much every population you'd care to look at. The things that are important, though, is to unpack what might be driving the difference between population groups. So why are Aboriginal people more likely to have chronic disease than non-Aboriginal populations? Poverty is important, disadvantage is important, exposure to poor environmental conditions are important, and these aren't shared the same across Aboriginal and non-Aboriginal communities. There's a whole range of reasons around being exposed to infectious diseases that might predispose Aboriginal people across the life course to more chronic disease. And then there's the fact that Aboriginal people are more likely to share those things all at the same time, to have diabetes and heart disease and kidney disease. And that's a potent contributor to whether or not you're going to have a bad outcome, particularly if you're likely to die. So we also know that the system isn't necessarily doing all the things it can equally across every population group. So whether that's access to coronary angiography or angiograms for people who are at risk of having a heart attack or have had one.
An angiogram is where you check the state of the heart?
That's right. You check the blood flow through the heart to see if there's blockages there that can be fixed. So then there's issues of resourcing health services. Do people in highest need get the most resourcing? Well, we know that that's certainly not the case. So there are some very complicated reasons and risk factors at play, and they all sort of mix up and are very hard to deal with. And then finally, we've really got to take into consideration the early life markers experienced by disadvantaged populations. There's some tremendous data from the US and other places now that show that if a child is exposed to adverse environmental conditions, if they've got a bad family environment, if they've got a parent who's got a substance misuse issue or a chronic mental illness or have been to prison, as adults those kids were far more likely to be smokers, to be obese, to be depressed, to be angry and to not engage in physical activity. So behaviours don't happen in a vacuum,
no.
And we need to understand those things to understand chronic disease.
Given all those factors at play, and they're diverse, we talk about the provision of healthy food in remote Indigenous communities, the appalling state of that. How preventable, though, Sally, are these chronic diseases? We know what they are. How preventable are they?
Very. Because if we dealt with the social justice issues of housing, clean water, adequate sewage, education and access to education, cleaning up the kids' ears from their chronic otitis media so the children can learn. A child who can't hear can't learn. And also the opportunity for employment and available employment, not just opportunity, but they are able to access employment. I think if we sorted those, now these, as the previous Prime Minister had said, was a black armband view or whatever, but however, those social justice issues are the rights of every Australian, not just black Australians. And if we sorted the social justice issues, we'd be doing extremely well.
This issue of how preventable is it? We only have to go back 30 or 40 years and look at how many Aboriginal people had chronic disease, and it was very, very few, if any. It's been this rapid transition into another way of life that Aboriginal Australians weren't prepared for. It was nothing that we were used to, and so we're now seeing the consequences of that. So how preventable it is, very preventable.
And I think there's a whole lot of things that sometimes as clinicians we don't push hard enough. And we're not talking here about being judgmental with patients, but we're saying, look, you know, if an Aboriginal person is a smoker, you do the brief intervention and you give them strong advice about quitting smoking, you know. And the same with alcohol and, you know, giving up the grog and things like that. There's ways of getting into those areas without being patronising or without being judgmental, where it's just, you know, clearly, you know, you're a doctor or a nurse or a health worker, you're a kind of a figure of authority, and sometimes that actually gives people an excuse to opt out of some social obligations that will continue them in some of the risk factor behaviour. So I think we've got to be fairly clear about some of those things, and I've often had other health professionals come to me and say, well, I didn't want to talk to that person about cigarette smoking because it's the last, you know, I've got a lot of other stresses in their life. But to me, within an empowerment process, what you're saying about that is, well, look, this is one thing they can actually have some control over, you know, or have a go at having some control over anyway, with your support and with the right, you know, infrastructure in place to support them to give up and things like that. So I think you know, we get caught up in the acute stuff because we know if we don't fix up their pneumonia, they'll come back tomorrow and, you know, bad things will happen. But if they go away still smoking, we think, oh, well, I don't want to ruin my therapeutic relationship with that person or anything like that. But in actual fact, they'll die of a smoking-related illness sooner or later, statistically. So I think sometimes we've got to be very clear and clean up our act a bit as health professionals as well, and not be scared to you know, really push good risk factor behavioural modifications. And Aboriginal and Islander people are not stupid. They know this, and they'll respond to things, you know. And it's come up lots, you know, for me, even within the prison system when I'm treating prisoners, and you'd think that was the last place they'd want to give up cigarettes, and heaps do. So I think there's some clear sort of guidance too.
Let's look at the current strategic directions and policies that are being used across the board to address chronic illness in Indigenous communities. We know what the government's policies are on chronic disease, but what do you think the policy directions ought to be right now for tackling chronic disease?
Well, I suppose this, you know, as a whole panel, there's probably lots we can talk about in this space. I'll try to be brief. We are currently sitting in a, you know, an unparalleled time of opportunity. There's never been such a strong focus on chronic disease in Aboriginal people. So, you know, now's the time if we're ever to make a difference. Current approach is really focusing on, you know, primary care infrastructure and systems. This is a very important part of the healthcare system to make a difference in chronic disease. My understanding of what's currently on the table is looking at risk factor reduction, so looking at helping people to give up smoking, helping people to lead healthier lifestyles, looking at better remuneration into primary care to better manage chronic disease, looking at employment of some alternative workforce to help people access services, increased access to specialist services through, you know, medical specialist outreach and what have you. So there's a whole raft of particular components that are being put forward. They'll have to be coordinated. They'll have to make sure that they deliver the goods across the board. They'll have to allow flexibility for local regions and local communities to set their own key strategic directions, I would think, because one size doesn't fit all, Sally, as you mentioned before. And I think that a one-off investment in chronic disease in Aboriginal communities will be problematic, and it should be ongoing because this problem is not going to go away.
Then what are some of the significant and exciting areas of research into our study of chronic disease?
Well,
what's the most interesting thing happening?
Well, I think probably the most interesting, you know, beginning of some work is really starting to look at this transgenerational or intergenerational chronic disease burden stuff, looking at how important the maternal environment is to passing on certain pathways to chronic disease in her children and offspring. I think that this area will be the most important, and I think it relates to that point we made earlier about, you know, behaviours in chronic disease doesn't occur in a vacuum. It really does occur within a context. So I think that the important research will be around understanding those pathways so that we can intervene as early as possible. And I think looking at alternative ways of dealing with chronic disease in communities, engaging the family. I mean, we talk about how important it is, and there's really no intervention trials yet that have focused on the family as the place where all the chronic disease prevention activity can happen. Looking at alternative workforce, nurse practitioners, physicians' aides. I mean, who knows what the workforce is going to look like, but it's going to not be just doctors in remote communities doing the business.
I think the other thing that Alex spoke about earlier was this, the transgenerational stuff around, you know, kids being brought up with various levels of trauma in their life, and I think that's one of the things that Yarrabah video spoke to. I think that how do you address some of those issues, because for the average clinician you're sort of going, oh, well, what do I do about the transgenerational stuff, you know? But the way they've done things there at Yarrabah's been fairly simple, and it's just an approach of empowerment. And these are some of the things I think we need to add to chronic disease programs to give them a bit more. I mean, it's qualitative kind of data, which, you know, most of us go pretty average. But in actual fact, we really need a lot more qualitative data because we have got a reasonable amount of quantitative data around what to do. It's how we do it.
The government's Closing the Gap health target is to close the gap in life expectancy within a generation. What are some of the ways this target's being addressed on the ground, or is it? I mean, we've talked... do you think it's a realistic target to start with, Sally?
No, I don't. I don't agree with that, because I think that is too short a time span and would be really virtually impossible to achieve within a decade, for goodness sake. How long has this been going on? I think it's an admirable objective, but I don't think it's possible. I'd like to think so, but I don't believe it is. I just want to go back a little way, if I may, to research when Mark and Alex, other researchers here, we've been researched and researched and researched, and there have been so many recommendations made, so many policies made. As a previous Aboriginal health leader said, if policies, what was it? If policies improved health, we'd be the healthiest people in this country, in this nation. And I think that that's true. The policies that have been developed that have not ever been implemented, if they took them off the shelf and implemented some of them, we'd be a lot better off.
I think, look, every person that works in primary healthcare will understand that there's political imperatives and there's a whole lot of ideological things that drive where the funding goes in policies, and that's and the two levels of government, which can kind of stuff up the best policies, and so things get driven in various directions and then just don't turn out to be very coherent on the ground. So your average clinician working there is going, well, I know this will work if I'm going to do this program, but they actually don't have the resources and funding to do it themselves on the ground, or the community has got insufficient infrastructure to make it work, you know. So it's a really challenging area, and I think it'll be great if we can get it going. But yeah.
Well, we've got some questions from our audience, some questions for the panel, and excuse me. I guess a lot of the questions focused on the Wellbeing program in Yarrabah. One of the questions is how are the outcomes from the Wellbeing program, how are they measured? What are the tangible outcomes and what are the obvious changes within the community? I think you could see from that package that it had quite positive effects on those men.
The initial research that was done around the men's group in Yarrabah was based on, it was participatory action research, so it was based on self-assessed improvements in their own, whatever their own targets were. So in the Yarrabah men's group, they had a lot of different areas that they wanted to improve in it, and a lot of them were more personal things like, you know, I want to spend more time with the wife and kids. I want to teach my kids, spend more time with the kids doing fishing and hunting and stuff like that. I want to have better communication. I want to do, there's a whole lot of things there, and measured over time, they showed significant improvements. But that's, you know, this is once again qualitative data, and it's actually hard when you're dealing with small groups of people to get good long-term quantitative data out of that. So I don't think we've, the Yarrabah group anyway has looked at how they're going to measure those, you know, hardcore health outcomes like drops in blood pressure and stuff like that, and better chronic disease control yet. But it's a good start, and it'll really help to inform us, you know, inform the evidence base around how we approach some of these programs from basic sort of work with men right up. But it's useful information.
So I mean, suicide rate, I mean, drops significantly. I mean, that's a pretty hard outcome, and a very good outcome for that process.
Another question from Paul in Goulburn. He says, in my experience, Indigenous communities tend to have higher rates of smoking. Are these statistics and other health-related statistics recorded anywhere so that health professionals can access them? It's a fair enough question.
Yeah, I mean, there's a you know, a wealth of literature out there about smoking rates in Aboriginal communities, ranging from data collected as part of the Australian Bureau of Statistics work, right through to the Aboriginal and Torres Strait Islander Health Survey that companions that every 4 years. And then there's a whole raft of policy papers on smoking, cross-sectional surveys of community members, men, women and pregnant women as well. So there is a wealth of literature. You could just Google smoking in Aboriginal and get an absolute packet of information.
The useful one is the biennial report from ABS and Institute of Health and Welfare, which has most of the data in it. It has a whole lot of that data that you can capture, and most clinicians can have a good look at and get updated on where everything's up to statistically.
The second case study, the Darugabinj Aboriginal Medical Health Service, has a chronic care program that looks at prevention, treatment and management of chronic illness. Part of the program is a healthy lifestyle program that covers nutrition, physical exercise and mental health.
The chronic disease management program at Darugabinj consists of 3 components. The first is prevention. The second would be screening, where we screen for people at risk and people who might have chronic disease they don't realise. And the third would be treatment of illness. The Healthy Lifestyle program is a series of sessions. There's 12 sessions and they cover things like healthy cooking, fats, serving sizes, food labels, exercise component. They talk about drug and alcohol, depression, and they cover other chronic diseases that affect our lives. I can see huge differences in the way people look at chronic disease management today. 2 years ago, there would have been heads in sand. It would have been overwhelming. They wouldn't have known where to start. The only thing they knew was that it kills them.
Oh, Suze, it's here, mate. That's for the Healthy Food Awareness Program, and this is the time, the schedule for what's going on. My name is Wayne Ritchie, and my position here is an exercise physiologist. Slide him up. Basically, we go to Namatjira Haven, we go to Woodenbong, out to Benalbo, Corrokai, Kyogle, and we just basically try to get the message across to people that, the Aboriginal people, just a little bit of education on just looking after their health. Yeah, mate, just got to grab the easel and we're right. I've got a heart here. Their coronary arteries would actually run down on the front of the heart, and you see all that white plaque in there? Well, that's actually caused by diet, genetics, lifestyle. There's a number of issues that can cause it. So I'm actually just going to find a coronary artery, and I'm going to just squirt a little bit of saturated fat through it. You can actually see the arteries blow up and block. Do you want to anyone want to have a go?
Oh, okay.
Yeah? Tell somebody 1,000 things, but if they can see it and actually do it and feel what they're doing, it sinks in more with them. So that sits close to your chest. The main health issues is obesity. That's rampant out in a lot of the communities. Like we've got people out there that are 150, 160 kilos and they're under 25 years old. And that's a really big thing, because if you put obesity to it's pretty much all the metabolic diseases in one. That's actually what a kilo of fat looks like. So, if you're 10 kilos overweight, we'd have 10 times that amount. If you're 40 kilos overweight, we'd have 40 times that amount. You just get the message, If you eat well and cut out your saturated fats, you're definitely going to live longer. I really mean that sincerely. But once your artery gets to that, you just got to plant that seed on their health and just let it grow and let them think about what was said, and then the next day they come along, they'll be a little bit more open to their health. And then the next time we see them, and that's how we do it. Yeah, it's just a real slow approach.
We have devised a number of multidisciplinary clinics. So, for example, if someone has diabetes, they need to have a yearly screening of a number of different types of disease processes. So we have a DCAC, a Diabetes Complications and Assessment Clinic, where they come in and that screening is all done on the same day at the same place. So they don't have to go to 8 different types of appointments over a long period of time, and that is much more culturally appropriate. We've also done the same with respiratory. Patients would have to go away for their spirometry and testing and then go off and see a specialist. We now provide that as the clinic, and they come in, they will see the nurse and have all their testing done. They will see an exercise physiologist and have their exercise levels recorded. Then they will go and see a respiratory specialist and have their lungs assessed and their condition diagnosed and treated. So it all happens on the one day.
And my people, like, they're so casual about things that if they come to town, and even if they come around to see the doctor, they would never say, look, check my blood sugar, see how it is, unless the nurse out here got them in and asked them about it, you know.
Just slow it up a bit, mate. You just come down to the chest height. Chest height? Yep, chest height. Nice and slow back. So it's 2 seconds down, 2 seconds back. Breathing in, breathing out. Breathe out. Keep your breathing good.
I like to use results because they're concrete. So I like to show patients their results. I like to give them a goal, a good result to aim for, and I like to use graphs and visual things so that they can see themselves improving. When they see their blood pressure coming down because they are taking their blood pressure medication, I think that's very powerful. You get them coming back then saying, so that worked, what else can you teach me? And then you've got a road in and you can teach them healthy lifestyle.
Chad, if you want to take it up a little bit more resistance, you just hit that button there on the right hand side. You see that there?
I was a type 2 diabetic, and I used to poke my needles in there. But what I did is just lost my weight and eat healthy food, no longer on needles at all. All I do is diet for my type 2 diabetes now. Yeah, you can change your lifestyle, you know, if you do the right thing, you know. Because it's up to you to motivate yourself and get out and do the things instead of playing with your sickness, you know. See, the doctor wanted to put me on pension, but I said, no, I'd rather work and get on pension, you know, because I've been active all my life and I want to be active till the day I die, you know.
I think we can deal with the acute, but overall, if we want to close that gap that everyone's talking about, we really need chronic disease to be the forefront of Aboriginal health.
Good to see they're having some success in Casino with the Darugga Binge program. I guess that leads to my next question, and that is, what are those strategies that work best in Indigenous communities? What health promotion strategies, Deanne, you'd be able to answer that question. What health promotion strategies work well with Indigenous communities?
Well, health promotion strategies need to be multi-layered. It's great to be able to work with individuals and families. So you've got the programs like the Healthy Lifestyle program that works with either it's a group-based program, or you have your brief intervention, which is a practitioner, individual sort of approach with the practitioner and the patient. But then you also need to look at those things that will support the individual to take up those healthy lifestyles. So if there's no food in the stores or healthy foods in the stores, then it's going to be difficult. So we need to address those things at that particular level, the local level, and also looking at, you know, expecting someone to go and do physical activity without the right environment needs to be addressed as well. So supportive environments, making sure there's food supply, those sorts of things, and a workforce to do that.
Yeah, of course. There are some systematic and effective primary health care principles which we know work well in Indigenous communities. They're things like consultation and community input. What do you say to that, Mark? I mean, they're obviously the really important principles.
They're really basic things, I think, and probably things we get the most wrong. Yeah. And the oftenest, you know, is that we say, yeah, we did some community consultation, which was a consultation of one. Often, we really need to get that systematic and work out ways of working with a broader community. And you know, it's not very smart to think you're going to get full community consultation, because, you know, you can't expect every person in every single community to want to put their hand up and come along and discuss their health every time that you run a meeting, because it's probably happened to them 15 times before anyway. So we've got to get the consultation part right. We've got to learn to delve down a bit deeper than just saying, well, what do you want? What do you think the issues are, and what do you want? And when people say nutrition program, we've got to go deeper and go, well, how would you like that done? It's when community mobs start telling you exactly how you can do it, how it'll fit in with what happens in their community, and that's really rich, important data that we often don't do anything with, partly because we're used to delivering services a certain way, and operationally, particularly for remote communities, you know, we have these cost efficiencies and a whole lot of other ways that we, you know, deliver our programs, and it doesn't always fit with the way that it should work most effectively for communities. So it's really important if we get the data to do something with it. Or once again, we've just done the consultation and let the community down, basically. There's a whole idea of being really systematic about care. So this is more than the audits we do of just the clinical notes of the people that go to the clinic regularly. And often you'll see that there's a lot of people that don't access the clinic regularly, and they're often the ones that need the help the most from the health service. So it's how we engage with the entire community systematically and regularly with that. So it's not about humbugging them and turning up on the porch every day for, you know, blood pressures and sugars, but it's about engaging people and letting them understand that the clinic and the service is accessible, the programs are accessible, they can be comfortable there, you know, with the health staff. And it's about us getting out a bit more of our comfort zones as health professionals and trying to reach out a bit more. And then all of the usual things are involved in this, you know, good quality improvement processes, using evidence-based clinical guidelines and sticking to them rather than just going off and doing what we sort of reckon is the best thing, you know. Look, there's a real need for us to monitor and evaluate ourselves when we're doing this to make sure we really are hitting the mark. And if we're not, then we've got to change. And it's not good enough for us to continue to do the same things over and over and over again and say, well, that's all we can do, because there's plenty more we can do, and we've got to evaluate it.
There's also just the logistical nightmare of getting people to treatment. I mean, people have to leave their communities for treatment, as we see in such large numbers in Central Australia. Those present major problems, don't they, Alex?
They certainly do, and we're creating, you know, when we talked before about how important connectedness is, we're actually disconnecting people for them to access services, and we're creating a whole range of sort of medical refugees, if you will, people who are completely dislocated from their family structures and community environments to just access services. Now, people accept that that's a reality, but it comes at an enormous cost, and we don't really understand or fully accept what that cost is, and it's borne by communities. We need to really understand that.
I think building on what Mark has just mentioned, building on that strength when you engage in community, you find out what the strengths of the community are and you build on those strengths. And so Yarrabah was a good example, as well as a New South Wales example, is being able to ask community what they want, how they want it, and when it's done. And going back to, you know, accessing traditional foods, if that's what people want to do, and if that's the easiest thing to do, then certainly health promotion people need to take into consideration, and other health professionals, about the strengths of the community, what they have there available to them, I guess.
Now to our next case study. How do we encourage self-management of chronic illness? Let's have a look at how one service is using an old concept with a new approach by personalising client-held records.
My name is Bernadette Heenan. I'm part of a team called the IPCI program, which is Improved Primary Healthcare Initiative. It's a program that started in 2006, and the idea was to deliver medical and allied health services to remote Indigenous areas to try and achieve better outcomes in chronic disease management. 95% of the clients I see are Indigenous Australians. Most of those people live up Cape York Peninsula or Mossman Gorge, which is about an hour and a half from Cairns. Mossman Gorge community itself has between 120 and 170 people. The percentage of diabetes in that community is anywhere between 30 and 40%. So diabetes generally in Indigenous Australians, you're looking at about 20% usually, and this can sometimes be seen as double that. Also, there's a high number of people with some of the end-stage complications. There's about 6 people from that very small community with end-stage renal disease who are on dialysis.
Down. Getting any better?
We work with a number of other health professionals in the diabetes section, dietitians, podiatrists, physiotherapists, psychologists, counsellors, GP, and also the person who's most crucial to the success of our team, our community engagement coordinator.
Well, I'll go tomorrow and see Herbie.
Yeah.
Just to let him know that
we're coming there. And just ask him to bring his monitor as well so we can see how his sugars have been going.
My job is to link the team with the community and get the community to feedback to the team on how we are to provide a service to them.
Hi Herbie, how are you? How are you today?
Good.
Yeah, oh, that's good. Hey, we've got Bernadette up there today, and she was wanting to see if you wanted to come up there and go through, have a catch up. It's always important to have an Indigenous person for the team's sake who knows about the dynamics around the community and what's happening, and for also the community people to come and feel comfortable to talk to me. I know, only because that funeral and everything, we put everything back. We look at some of the underlying issues, which is part of what my job is as well, to help the team to recognise those and to get the community to tell me what those underlying issues are that contribute to this high number of people in the community with chronic disease. Hello, hello. How are you?
A lot of how we deliver our services has been tailored to suit our clients. So we don't just work in clinics, we'll do home visits. So we provide services wherever there's a need for it.
You've got something happening with your monitor and you want to see Bernadette, so I'll let her sit down and you can find out what the issue is there.
So what's been happening? Fighting fit and healthy and everything?
Yep.
Yeah, and I see you brought your folder and everything. We came up with the idea of a self-management folder that belongs to them. So rather than having all the information about their body, whether it be blood tests, blood pressure, blood sugar, etc., being kept in the files either at a GP or at a clinic, the idea is that it's actually given to the person. So back in March it was 10.4, that's your average sugar over the last 3 months, and it's come down to 7.4, you know, in about 3-4 months later after that, and that's the best it's ever been, so that's awesome.
Good.
Yeah, look, we always try and put clinical measurements like a blood pressure and a blood sugar and a waist measurement into the folder at the time of doing it, so that the person understands the relationship between the tests that have just been done and the actual results, so that it's basically giving immediate education.
Having my own folder helps a lot. I know where I'm at and all that. That's pretty good. I like the diagram that Bernadette drew up for me. Explain a lot on how to take your food and all that, what to drink and how it's, whatever you take, it goes into your bloodstream and all that. And she keeps me up to date with all this here.
The idea also is that the information can be shared between all the different service providers who assist the client to look after themselves and manage their diabetes. So there's a calendar at the front of it showing little icons of people who are involved in the care for someone with diabetes, and we encourage the person to take the folder with them to other healthcare providers.
Yeah, if you go to the doctors and they give you that number, and they ask them, and you can take this folder with you to whenever you get your blood pressure done.
Blood pressure, I've got one of these. So.
We try and educate at every opportunity rather than just writing things on one little scrappy bit of paper, so that they can plot changes and explain, well, your blood pressure's crazy today, did you take your tablets? If not, then we'll also write that on as a note on the paperwork to show. Then when they take their tablets and we do their blood pressure later, you can see the difference. So just pop it in like that. One of the things we've found is that when we educate people and make them feel in control and empowered, they actually gain quite a bit of confidence and they become experts in doing maybe their own blood glucose monitoring or in maybe understanding various aspects of their care.
I've learned a lot now about diabetes, and I've learned to just talk to my kids, to watch themselves from eating sweets and whatever.
you can see how it used to be. You know, you had sugars way up in that range.
Yeah.
And now they're all in that range there.
We've seen some people definitely start to become the boss of their diabetes, and sometimes you can measure this in figures. So we've seen some people with an HbA1c of 10% when we first met them, within a few months come down to 7%. But along with that usually goes improved blood pressure as well, and always an increased knowledge of what has made that change happen. So yeah, we've seen people take on ownership and acceptance and yeah, get in the driver's seat of their diabetes.
Some great work being done up in Mossman Gorge. What's some of your reactions and comments to that case study? I mean, it was great having a community engagement officer walk into the community and really be part of the delivery of healthcare.
Absolutely. Can I just say that that's the most fantastic team I've seen in a long time? And then can I also add that they're now working for Punapima, my organisation, so I'm a little bit biased there, but in actual fact, they are. And that team's a fantastic team, and they work really well with communities. And as I was saying, one of the keys is good community engagement. There's various ways of that working, so we'll engage at different levels, with the council, with the men's group, with the women's group, with various teams like our health action teams in communities, and volunteers who work on health in communities, right through to individual community engagement officers like that. The program works effectively, and it was working very effectively before we took it over. So the Far North Queensland Division of General Practice originally ran that program. It's been great. One of the things that we've been working on with that team is how we ensure that the person like the community engagement officer, now because, you know, and I think they are the critical play the central role there, but unfortunately they're usually the lowest paid as well. So this is about workforce as well. So one of the things that the team's working on is how we encourage people like you saw Keely there, the young community engagement work. Fantastic. And you know, as a person that's involved in Aboriginal health workforce, I just can't go past a person like that and say we really need to be able to develop them more so that they've got a career structure, so we can build on that, we can build on the skills that they have of working with people, we can build on their medical and health knowledge in any direction they want to go, really. But it's part of the workforce process as well, but engagement's hugely important.
I think a really critical question, and I address this to anyone on the panel, and is it the self-management of chronic disease? Is it a bit rich to ask the most disadvantaged communities in the country to self-manage their chronic disease?
Well, I think that it's problematic. I think what that last case study showed was how important good communication with your client is, and then, you know, anything's possible. And it's just fantastic to see that, you know, people are supporting good communication with clients around their condition. And I think that's something that we've lacked in Aboriginal communities. The issue of self-management is a complex one and a problematic one for me, because I think in disadvantaged populations it's very hard to expect them to step up to the plate and pull themselves up by their bootstraps and manage their own conditions, which are often conditions they don't fully understand, which haven't been communicated well, which are labels they don't necessarily comprehend or accept or agree with and don't understand, and then expect them to lead a life of, you know, doing all the things that we tell them to without creating an environment around them where they can make those choices to lead a healthier life. So I think it can set up people to fail. I think the importance with really the case study from Casino was really about setting realistic targets and helping people achieve those, and how that was a very positive way forward. I think self-management can be problematic in disadvantaged communities where they don't have all of that infrastructure around to support behaviour change.
What's the importance of training Indigenous health practitioners? We know how important the work like you've done, Sally, but how important is it getting, you know, our people trained up to work in our communities?
Extremely important. The community engagement coordinator, what a wonderful example that was, and there should be more of them, certainly. And if it's necessary to create a career path for them, in whichever for their level of expertise, and if they wanted to stay in that role, they should be remunerated appropriately for the valuable work they do. And it's the same with Aboriginal health workers and the wonderful job that they do. And we couldn't function without them out in the remote communities. I would like to think that CATSN, my organisation, the Congress of Aboriginal and Torres Strait Islander Nurses, and the Aboriginal health workers have a good relationship, and we have done thus far, and will be even better now that they've have their own Aboriginal Health Worker Association set up. And I think that that's really great, and I think that they don't get as much good publicity as they should have.
What can the mainstream services learn from this kind of example, this model, Deanne Minicon? I mean, you know, this is how Indigenous people do health, isn't it?
Yeah, by engaging, again, local workforce, using the local workforce. They know what's going on in the community. They know when the professional should come in or when they shouldn't come in. But at the same time, we certainly do need to build up the health professional workforce also, whether it's across medicine, nursing, nutrition, you know, podiatry, optometry. We also need to build up those positions in policy, you know, so that we have Aboriginal Islander people working in those areas to direct policy to suit Aboriginal Islander people as well. So right across the health workforce, not just in specialised areas. Yeah.
Now we've got some questions from our wonderful audience, and the first question is from Aaron, and he's working in an Aboriginal community. I'm part of a diabetes team in an ACCHS, an Aboriginal Community Controlled Health Service, and I found more people starting on insulin because they have control over their dose. It's a small area which improves concordance and enables health education to occur at the same time. Can we call that empowerment? I mean, that's Aaron's question.
Oh, I mean, I think you can. I mean, empowerment comes in many different colours and faces, and it has many different facets to it. I think people maintaining a sense of control over their medication regimes, the way in which it's delivered, is all part of that process. We're starting to see, you know, more people, more Aboriginal people on insulin. That's both probably a good thing and a bad thing. Good that people are taking that option. A bad thing that there's a need for that. But I think that, you know, there will be medical solutions, I think, in the future which will make insulin and long-term diabetic medication easier for communities in the future.
Another question here. I agree that empowerment and not spoon-feeding is essential for long-term meaningful change, but when someone is not in a frame of mind to be empowered, how do we generate the desire from within? Especially when there is no acute disaster, for example, suicide rate, to spur people into action. How do we change from passive acceptance to proactive action?
Yeah, look, I think we've done a bit of work with men's groups on this in various locations. There's always a locus or a nidus of people that want to be empowered, that want to do things, that want to take responsibility in communities. There's always some, you know, in every Aboriginal and Torres Strait Islander community that you can build on. It's just finding them, identifying them and starting to work with them. And it may not be everybody, and empowerment as a process may not work for everybody. Its roots really lie in education in disadvantaged communities from South America, and it's been proven to work pretty well in that area, as well as there's been WHO evaluations of empowerment as a process for health promotion particularly. But getting someone to the stage where they are happy to accept another person's input into, you know, where they're going in life, a lot of that depends on the way that you communicate with them and the way that you engage with them from the start. And you have to really ensure that you're, you know, a lot of this is about the way that we project culture or dominant culture or whatever with people that we're working with. And we have to be really clear that we're approaching it the right way for a start. And the second thing is really finding out where people are at. And if people are like clinically depressed or there's other issues going on, they're probably, you know, they're not going to respond that well. But the idea of this is to work with people in the long term, not just to expect that they'll suddenly go, wow, I want to be empowered. It's more about sort of a long-term process, engaging with communities and individuals over a long term, and actually building trust, relationships, and, you know, as most people that work in Aboriginal communities know, it's all based on relationships, not how good a professional you are, but your relationship with a person. So my answer would be, yeah, that you continue to work with people, and that you never give up, because it's hard enough when Aboriginal communities themselves lose hope, but when the health professionals lose hope as well, you're in real problems. And
we have to remember too that these sorts of experiences are not just for Aboriginal Islander people, it's for all people, and so how you deal with that in other communities is going to be similar. We just got to remember what Mark had just mentioned, is think about our own cultural baggage that we come into the communities with and how that's going to affect the way that we deal with individuals.
I'd like to thank our audience for those questions. We didn't get time to all of them. I guess now we have to think about what our take-home messages are from each of the panel. Could I start with you, Sally? What do you want people to take away?
I'd like to think that people would consider tolerance, acceptance, look at the principles of reconciliation, and also look at why we're here tonight. Why are we here tonight if we're not hoping to make a difference? So that we can make a difference with Aboriginal and Torres Strait Islander health, that we can work together for the greater good.
Alex?
Yeah, I suppose, you know, I do get asked this question quite a bit. I suppose the first bit of advice I'd give is if we delivered everything we knew we should deliver, we'd make an enormous difference. So reduce the gaps between evidence as we know it and evidence as we practice it, will make a huge difference. I think Mark just touched on an important point. You know, if health practitioners give up hope, we're in trouble. So don't give in, and certainly don't give in on your patients. You know, it might be the first 10 or 20 times you see them, they're not interested in engaging with you, but at the 30th visit or the 40th visit, that might be the opportunity to make a real difference and change in that person's life. So never give up on your patients, and really bring to the table what it is that you do better than anyone else and contribute that into Aboriginal health. And if we all do that, we'll make a huge difference.
Deanne Minicon, your take-home message.
Yeah, that it is everybody's business to improve Indigenous health. But one of the key things would be to value Indigenous knowledge, to value your workers that are there in that community and your local community. But yeah, basically to value that knowledge that's already there.
Mark?
I guess from my perspective is, we're all trained really well in acute medicine. Doctors and nurses, especially allied health and health workers, are probably better trained in broader aspects of health. But doctors and nurses, don't hit me, we really are well trained in that area, and we've got to start thinking outside of that area. And it's a challenge for us to do that, to think about populations and public health approaches and how we do targeted interventions and how we respond to audit trails and a whole lot of other things, you know. But the key is, I think, to not be defensive, is to say, look, we don't, you know, we've been doing a lot of acute medicine, now we need to change the way we do things and look at chronic disease models and take it on board and start working with it, because we'll see results. And there's documented evidence in Australia that, I mean, Alex has published on this, where you can do good, systematic, comprehensive primary healthcare and it works and there's results, and you see decreases in mortality rates. So that's what we all want. And I think we can do it. We definitely can do it. And it's just a matter of us staying focused on at its broadest sense, good primary healthcare from my perspective. So.
Thanks to our wonderful panel. I hope you've enjoyed the program, Sharing Solutions, Indigenous Communities Tackling Chronic Disease. If you're interested in obtaining more information about the issues raised in the program, there are a number of resources available on the Rural Health Education Foundation website at rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Daniel Browning. Good night.